Welcome to Derm Drop, your TLDR in dermatology. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other interesting sources in the dermatology community. Episode 11 includes segments on preventing psoriatic arthritis, bullous pemphigoid bullet points, jacked up nails, and spotting cutaneous Crohn's. Let's get started. Can psoriatic arthritis be prevented? It can and should. A study published 3 July 2025 in Rheumatology, the Journal of the British Society for Rheumatology, looked at 946 patients with severe psoriasis and compared those treated with TNF inhibitors to those treated with narrowband UVB for 10 years and found that the psoriatic arthritis incidence rate in the TNF group was less than half that in the phototherapy group. In fact, it was 10.7% versus 22.2%. Applying a time-dependent Cox model to the data brought the hazard ratio down to 0.32 for the TNF patients, so even lower. What about other biologics? A study published 24 February 2025 in the Annals of the Rheumatic Diseases found that IL-17 and IL-23 blockers performed even better, with 5.5% and 4.3% in those groups developing psoriatic arthritis over a 4-year period compared to 14.2% in the TNF group. After inverse probability of treatment weighting to balance covariates such as age, BMI, and psoriasis severity across cohorts, the hazard ratios were 0.63 for the IL-17 group and 0.57 for the IL-23 group relative to the TNF group. How about conventional DMARDs? A study published in the March 2025 issue of Joint, Bone, Spine found that methotrexate lowered the risk of psoriatic arthritis too. Late initiation, greater than 2 years after psoriasis onset, had an incidence rate of 2.66 events per 100 patient years, adjusted hazard ratio 0.36, and early initiation, which was less than 2 years after onset, had an even lower rate of 1.07 events per 100 patient years, adjusted hazard ratio 0.24, compared to 4.45 events per 100 patient years for controls receiving non-DMARD therapy. The benefits of early intervention were reiterated by another recent study published 23 June 2025 in ACR, the Journal of the American College of Rheumatology, which found that all DMARD classes, including conventional synthetics such as methotrexate, targeted synthetics such as tofacitinib or apremilast, and biologic such as adalimumab, etanercept, certolizumab, golimumab, infliximab, ixekizumab, secukinumab, abatacept, ustekinumab, or guselkumab, initiated less than 1 year from psoriasis diagnosis, the mean was 0.2 years, were more than twice as likely to achieve minimal disease activity as those that delayed initiation for more than 1 year, with an 8.6-year mean. The take-home point, maintain a low threshold for early systemic therapy. Since psoriasis manifests in the skin 7 to 10 years before the joints, dermatology clinicians have a unique opportunity to reduce the burden of this debilitating disease. Thanks to John Cush for highlighting recent research in this area on Rheum Now. With dupilumab's back-to-back FDA indications, it's bullous pemphigoid's turn in the spotlight. So here are DermDrop's BP bullet points for busy providers. Up to 30% of BP patients have oral mucosa involvement. 20% are non-bullous. BP can be eczematous, urticarial, or just plain itchy. Prodromal pruritus without lesions can last weeks, months, or even years. Mean diagnosis delay, 29 months. So consider checking serologies in all itchy older patients. Those are BP 180 and BP 230. BP 180, also called BPAG2, is more sensitive, but BP 230, also called BPAG1, may be the only marker in milder localized disease. So get both. Direct immunofluorescence is even more sensitive and 100% specific. In bullous presentations, punch the adjacent red skin. If there's no red skin, punch the adjacent normal skin. In non-bullous presentations, punch the lesional skin, not the perilesional skin as you may be used to. What if you didn't get a DAF? Here's a hack. If BP wasn't on your differential and all you got was H&E, ask your dermatopath to do C3D staining on formalin-fixed tissue, as it is a marker of complement activation. Indirect immunofluorescence can help distinguish between BP and other subepidermal blistering diseases, such as epidermolysis bullosa acquisita. So you've confirmed the diagnosis. Now what? First off, consider changing bullous pemphigoid driving medications if possible. These include aldosterone antagonists such as spironolactone, DPP-4 inhibitors such as sitagliptin, anticholinergics such as oxybutynin, dopaminergics such as levodopa, and immune checkpoint inhibitors such as pembrolizumab, which can trigger bullous pemphigoid even after discontinuation. And you want to collaborate. Bullous pemphigoid patients have a 5-fold higher cardiovascular disease mortality risk. Let's talk about treatment and start with a tweak. Nicotinamide might reduce potent topical steroid use in mild disease. All other systemics, however, for example, doxycycline, dapsone, methotrexate, omalizumab, rituximab, etc., have unfavorable side effect, safety, lab monitoring, and/or access disadvantages compared to Dupixent. Before dupilumab got the FDA approval, there was a fair amount of pre-approval data. For example, there was about 75% complete response rate in a 2023 meta-analysis of 63 bullous pemphigoid patients treated with Dupi and oral corticosteroids or other immunosuppressants. And there were a lot of other case report, case series, and cohort study success. So let's look at the ADEPT Phase 3 randomized controlled trial design. All patients were started with a prednisone or prednisolone taper, which is very real world. Flares after the taper, however, were considered failures, which is not very real world. The ADEPT results? Well, sustained remission was seen in 18.3% of the dupilumab treated patients versus 6.1% of the placebo-treated patients. That's about a 3x difference. 4+ itch reduction was seen in 38.3% of the dupilumab-treated patients versus 10.5% in the placebo-treated patients. That's an even greater than 3x difference. And in terms of cumulative oral corticosteroid dose, 2.8 grams in the dupilumab patients versus 4.1 grams in the placebo patients, which is about 1/3 less in the dupilumab group. The percentages might be underwhelming, but the deltas are pretty decent. And in practice, you're going to expect occasional flares and treat them as indicated without considering them a treatment failure. So your percentages are going to be higher. Will it be monotherapy? In mild cases and maintenance phases, it can be. But moderate to severe cases will typically require a prednisone taper initially to put the fire out. Just be sure to taper slowly once the control is achieved to prevent relapse. With no new adverse events or safety signals in this population, Dupi's approval will improve quality of life while reducing steroid exposure, adverse effects, lab requirements, and access hurdles for bullous pemphigoid patients. Thanks to NYU Langone Health Assistant Professor of Dermatology Prince Adotama, MD, for the BP Pearls. Jacked up nails got you down? Jack them up instead. Nail disease is up there with hair loss in terms of psychosocial impact due to nails' aesthetic importance in contemporary cultures. Plus, there's the added functional impact due to their utility in daily tasks. And when it comes to treating nail disease, the phrase tough as nails is especially apropos. Nails are hard, well, except when they're brittle, and then we want them harder. So JAK inhibitors to the rescue. In a systematic review published 23 April 2025 in the American Journal of Clinical Dermatology, the authors looked at 31 studies to evaluate JAK, including TYK2, inhibitors' therapeutic potential in inflammatory nail disease. Evidence was found for tofacitinib or Xeljanz, baricitinib or Olumiant, upadacitinib or Rinvoq, abrocitinib or Subminco, and deucravacitinib or Sotyktu. Data for ritlecitinib or Litfulo and the topical formulations ruxolitinib or Opzelura and duruxolitinib or Anzupco were not found. Use of compounded tofacitinib 2% ointment was reported, but in terms of FDA-approved formulations, we're talking about orals here. The authors acknowledge that clinicians may be reluctant to prescribe a systemic therapy for such a low body surface area, but topicals have relatively low bioavailability, while oral JAK inhibitors have a track record of safety in this population with typically mild adverse events reported, most commonly nasopharyngitis and transient laboratory abnormalities. On the other hand, pun intended, non-steroidal oral medications such as acitretin and alitretinoin, which is not available in the U.S., used for nail lichen planus have limited efficacy in severe disease and treatment-limiting adverse effects. Systemic corticosteroids have better efficacy, but worse potential adverse effects. And perilesional Kenalog injections are no fun for anybody. Different inflammatory nail diseases involve different cytokine profiles, and different JAK inhibitors hit different cytokine pathways. So which JAK should use in which disease? The no-brainer use cases are the onychodystrophies due to conditions with FDA indications already. For example, psoriasis, use deucravacitinib. Eczema, you've got abrocitinib and upadacitinib. For alopecia areata, baricitinib, including cases with concomitant atopic dermatitis, as baricitinib has the AD indication in Europe. What about the orphan nail diseases? Well, try these pairings. For lichen planus, tofacitinib, baricitinib, abrocitinib, and likely upadacitinib based on mechanism of action. For acrodermatitis continua of Halopo, it's the same, plus deucravacitinib. Interestingly, tofacitinib was effective in a number of tracheonychia cases without a diagnosis of the underlying etiology. Just be patient and give it at least a 6-month trial, as slow plate growth and reduced drug penetration mean that even JAKs need time to fix ragged toenails and fingernails. Lastly, if your patient has intractably painful intertrigo, it might be cutaneous Crohn disease. Derm clinicians are unlikely to miss a perianal fistula that communicates with the gut in a patient with known Crohn's. But can you spot metastatic Crohn disease? Metastatic Crohn disease is non-contiguous with the GI tract and typically affects the inguinal region, genitals, buttocks, and oral cavity, but can also affect ectopic regions such as the abdomen and thighs. Unfortunately, you can't always rely on a history of GI issues to guide your diagnosis. Metastatic Crohn disease has been reported in patients without intestinal complaints, as it may manifest before inflammatory bowel disease. Hard to believe? Check out the case presented at the Society of Hospital Medicine Converge 2023. And the one published 26 November 2021 in Advanced Biomedical Research Journal. Further complicating the diagnosis is the association of Crohn's with other skin diseases such as hidradenitis suppurativa, pyoderma gangrenosum, erythema nodosum, and epidermolysis bullosa acquisita. Until now, there have been no established diagnostic criteria. That's why a Delphi panel of 19 U.S. experts from gastroenterology, dermatology, and dermatopathology was convened. Their consensus results were published 7 May 2025 in JAMA Dermatology. For non-oral locations, patients need 1 major and 1 minor, 2 major, or 3 minor criteria. The major criteria include genital swelling, genital lymphedema, or genital, inguinal, or intertriginous knife-like ulcers. The minor criteria are perianal skin tags, genital fissures, non-healing genital ulcers, a suggestive biopsy, or inflammatory bowel disease diagnosis. You'll note that that's optional in this case. Oral disease, however, does require a history of inflammatory bowel disease, but only one of the following additional criteria: sublingual edema, linear ulceration, oral aphthay greater than 1 centimeter, piostomatitis vegetans, or granulomatous chylitis. A biopsy is not required, but if you do one, naked granulomas without infection or other more likely diagnosis are sufficient to make the diagnosis. And any of the following histologic characteristics are suggestive of metastatic Crohn disease: epithelioid granulomas, non-caseating granuloma with ulceration, vasculitis, or lymphocytes and eosinophils, loose granulomatous and lymphoplasmacytic inflammation, and intravascular histiocytic aggregates, plus perivascular perilymphatic lymphohistiocytic granulomas. As the authors note, establishing diagnostic criteria will reduce delays in identification and therefore the progressive pain and disfigurement of metastatic Crohn disease. So that severe intertrigo is cutaneous Crohn's. Now what? Well, select treatments as indicated. Your topical options include corticosteroids, calcineurin inhibitors. Your immunomodulators include methotrexate, azathioprine, and prednisone. Biologics include TNF alpha and IL-23 inhibitors, and antibiotics are typically metronidazole. Then refer to GI for co-management. That's it for episode 10. Derm Drop is written and hosted by me, David Sider, with production and distribution by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/n/Dave-Sider, spelled Seiter. Questions and comments can be sent to us at dermdrop@gmail.com. If you learned something useful, hit the thumbs up button and tell a friend. Thanks for listening, and tune in again in 2 weeks for the next episode of Derm Drop, your TLDR in dermatology.